So after we go into the operating room, we have our anesthesiologist do pectoralis level 1 and 2 blocks. Basically, once the patient is under anesthesia, they can localize the nerves of the chest between the muscle layers with ultrasound guidance. And it does kind of help numb, it's kind of like an epidural of the chest. So it's a regional block and it helps numb the chest. So it's easier for patients to transition onto oral medications. So we all do a short course of narcotic. Oftentimes that's like Norco or hydrocodone or oxycodone. And patients usually don't require much of it, maybe a few days. So it is truly a short course before we have patients transition just onto Tylenol and ibuprofen. So we have patients hold ibuprofen for 3 days, but kind of keep doing Tylenol around the clock. It is dependent on the surgeon whether they leave drains or not. Some surgeons will leave drains, others won't. And sometimes it's just case by case or dependent on the amount of reduction that is being done. So the drains can stay in from anywhere for days to maybe a week. But otherwise, all the sutures are under the skin and dissolvable. And we just have patients wear a bra for those first few weeks, kind of around the clock, other than to shower. So patients will be sleeping on their back, and we want to keep the breast supported, keeping tension off of the repairs. So we have patients wear bras at night, and they're post-operative bras, so they're the ones that close in the front. I think what we worry about is, it's hard to know what you're going to do in your sleep, and so we don't want patients to roll over onto their chest and potentially cause trauma, which could always incite something to start to bleed. But oftentimes we see patients post-op day 1 or 2, and they're already off of narcotic medication onto just Tylenol. So I would say overall, it's a well-tolerated procedure.